thank Greg and the staff today for inviting me. It's the first time, my first time in Athens since over 30 years, and the previous time I was here, I was a member of the national swimming team of Belgium, so it was a different setting. So I'm going to talk about why I think TAVR is a very good idea for patients with bicuspid aortic stenosis, and Dr. Chalapas already did a very good presentation and set the stage for my talk, as you will learn. These are my conflicts. So first of all, a couple of facts. So bicuspid aortic stenosis is not exclusive to younger patients. Apparently, 20% of the octogenarians have a bicuspid aortic stenosis. And sometimes it's a matter of semantics, because sometimes it's very difficult to differentiate between functional bicuspid and congenital bicuspid disease, but still, 1 in 5 of the octogenarians. And so far, bicuspid has been excluded from the randomized trials, but there are some clear trends in TAVI or TAVR, and that is that we are tackling younger patients at lower risk with a longer life expectancy, and still there is this issue, or not, in terms of durability with these transcatheter aortic valves. So we need prospective research in TAVI, and that is on the way. Again, bicuspid aortic valves can be separated in terms of the raphe, the presence of the raphe, and the majority of the cases relates to patients with a type 1 raphe, and a lot of those type 1 raphes end up being functional bicuspids, so they are truly tricuspids. And this is the CT classification that also was shown by Dr. Chalapas. And basically, a lot of the patients, they will have 3 commissures. And so there is a raphe that then will separate or will connect 2 commissures to become a bicuspid. But a lot of those patients will have 3 commissures. Even in the bicommissural, sometimes it can be very difficult. Is this now 3 commissures or only 1 or only 2 commissures? So a lot of those cases are not so straightforward. So I think a lot of those cases could be eligible for a TAVI. So what is bicuspid aortic stenosis in contemporary practice? I did this prospective registry together with my friend Didier Tchetché a couple of years ago, where we looked into all patients who were admitted for an aortic valve replacement to our practices. And this was a prospective study from November 2017 to February 2018, so only 4 months. We gathered 920 patients. 15% of those patients were identified as having a bicuspid aortic stenosis. And the first diagnosis of bicuspid was made by echo in 60% of the cases, and by CT scanning in 35%. And still there was a number of patients that only the bicuspid could be identified during the open surgery. Type 1 bicuspid was present in over 80% of the cases, and as expected, the majority of patients were younger. The mean age was 66 versus 77 years of age of patients with tricuspid aortic stenosis. And most frequently, these patients had mixed aortic disease. So it was a combination of aortic stenosis and aortic regurgitation. The majority of those patients were still being treated with surgery, as shown here. So what are the challenges with bicuspid aortic stenosis in terms of tackling these with TAVR? Well, first of all, it's an oval and large annulus. They are severely calcified, and there is an abnormal or an atypical calcium distribution. Sometimes it can be a challenge to cross the orifice with a wire, and there is concomitant aortopathy in 50% of the cases, so there are some anomalies in the elastin, so there is connective tissue disorder that also may affect the procedure along the way. And how do we need to define the virtual annulus by angio if we have a bicuspid aortic stenosis? So there are all kinds of issues related to this. Well, with the first generation of devices, the results with both SAPIEN XT and CoreValve, they were not as good with bicuspid in red as compared to tricuspid valves in blue in terms of paravalvular leaks. In principle, especially with the self-expanding devices, PVL was much higher in the bicuspids, but with the next generation devices with SAPIEN 3 and, for instance, Lotus, but also with Evolut Pro, the differences between bicuspid and tricuspid valves in terms of clinical outcome, including paravalvular leaks, is not significant anymore. So the new technology really improved outcome in patients with bicuspid aortic stenosis. And in this study by Yoon, which is a retrospective analysis, the outcome, the clinical outcome, at least to 1 year, so relatively short term, was completely similar between bicuspid and tricuspid aortic stenosis after TAVI. And this is a couple of devices that we're using in my practice in Erasmus, with a Lotus valve, a Sapien, and then an Evolut Pro. And in principle, you might end up with quite good results in terms of gradients and no PVL, but this is a typical example that you can encounter. And this was one of our earlier experiences. This was a Sapien XT, but I liked the image. And it clearly shows that we created a dissection in the ascending aorta. And we modified our practice along the way. In the beginning, we treated a bicuspid aortic stenosis as we treated a tricuspid valve, and that was a mistake because sometimes it can be very difficult to navigate through the bicuspid aortic valve and enter into the LVOT. And in this particular case, we had been struggling to get our Sapien valve across the bicuspid valve, and we ended up dissecting the ascending aorta. This patient eventually did well, and we ended up doing the case with a relatively good result in terms of the valve performance, but there was some kind of excitement related to the ascending aorta, but this healed up over time, and the follow-up CT was basically quite satisfactory. But still, following that particular case, and I must admit we have another case where we also had an ascending aorta dissection, we now do a pre-dilatation in all our bicuspid valves as compared to tricuspid aortic stenosis, where we don't do balloon pre-dilatation anymore. So this is the BAVARD study, or results from the BAVARD study, and also Dr. Chalapas referenced this multiple times. This is a study that was recently published in Circulation Cardiovascular Intervention. It also included 100 patients with bicuspid aortic stenosis, and we compared them, we propensity matched them with also tricuspid aortic stenosis patients. Again, the majority of the patients had a type 1 RAFE, so Sievers 1 bicuspid aortic stenosis. And what was interesting is that there was no difference in mean prosthesis to annulus ratio for BAV, for bicuspid or tricuspid valves, and also the sizing ratio between the prosthesis and the intercommissural diameter for bicuspids and tricuspids was relatively similar. And of course, more oversizing was being done with the self-expanding Evolut device relative to Sapien or Lotus. So in conclusion of the BAVARD, basically, and so there are several hypotheses. Some people say, well, you have to be very careful with the commissures because there is all the calcium in bicuspid aortic stenosis. And people were already advocating that it's really mandatory to do your sizing and base your sizing on the intercommissural distance, 4 millimeters above the annulus. And I must say that Didier and I were a little bit on opposite sides. So he was a proponent of that strategy, and I was more like, no, we have to approach these valves like we approach tricuspid aortic stenosis. Well, at the end of the study, we came to the conclusion that ellipticity and size at the annulus level was the same for tricuspid and bicuspids. Ellipticity and size was the same for bicuspid and tricuspids at every level above the aortic valve annulus. And this has also been shown by Dr. Chalapas, and it shows that only in 14% of the cases at the intercommissural level there was a tapering, and so it was smaller than at the annual level. So only in 14% of the cases, in my opinion, it makes sense to downsize relative to the sizing based on aortic annulus. And of course, with the tricuspid valves, we are sizing based on the aortic annulus. So I think I take that into consideration. So of course, we look at how the aorta looks like at the commissural level, but also at the annulus and even below the annulus, because in 1 in 3 of the cases, the anatomy will taper down into the left ventricular outflow tract. And so if you oversize too much at the level of the left ventricular outflow tract, you will end up with more pacemakers and conduction disorders. So it's more than just relying on the virtual annular plane of the aortic valve. You have to take into consideration the intercommissural level and the LVOT level, but all in all, only in a minority of cases you will need to downsize at relative to the intercommissural level. And this is data that has been presented 6 weeks ago by Raj Makar at the ACC meeting. It is it comes from the TVT registry, and it looks into the results of SAPIEN 3 in bicuspid aortic stenosis, and comparing them also with the results with SAPIEN 3 in tricuspid aortic stenosis. And to my surprise, almost 2,000 or more, almost 3,000 patients were already being treated with a SAPIEN 3 for bicuspid aortic stenosis in the United States. So quite a significant number of patients. And if you compare those patients to the tricuspid aortic stenosis, as expected, patients with bicuspid E were younger and had a lower STS score. But interestingly, they were less frail, or as expected again, they were less frail than the patients with tricuspid aortic stenosis. If you then do a propensity score matching, what they did, so they identified 2,691 pairs of patients, so over 5,000 patients with bicuspid and tricuspid aortic stenosis. Then they were well matched with a mean age of around 73 years old. Then it was clear that patients with bicuspid aortic stenosis ended up with the largest SAPIEN 3 valve in 1 in 3 versus 1 in 4, a quarter of the patients with tricuspid aortic stenosis. So you probably will end up with larger sized valves because the anatomy, the dimensions in a bicuspid valve are larger. And then the need for rescue surgery, annulus rupture, stroke, and pacemaker was slightly higher with bicuspid aortic stenosis, but still at the low end, less than 1% of rescue surgery, annulus rupture, and pacemaker rate somewhat higher, but still in the single digits. So these results, at least from a procedural perspective, are quite satisfactory. And at 1 year, again, the results were completely similar between bicuspid and tricuspid aortic stenosis treated with the SAPIEN 3. Also interesting in terms of PVL, there was no difference in severity of PVL after the valve, and the gradients after the procedure were also similar between bicuspid and tricuspid. At this point in time, there is a prospective registry ongoing in Europe, where it's called the BAVARD X. We are looking at several sizing patterns, sizing paradigms, and we are comparing them. So some of the centers are sizing based on the intercommissural level. Other centers, like my center, are just focusing on the annular level, and only if there is significant tapering at the intercommissural level, we would address or adjust our sizing algorithm. And then we are comparing whether that would affect our outcomes, and we have a CT, EKG, an echo evaluation during follow-up, and there is a core lab CT and echo analysis being organized. So TAVI for bicuspid aortic stenosis, it's all a matter of planning. And I think if we move to younger patients, and we discussed already the low-risk trials where the mean age was 74 years old, so does that mean that we also need to treat the 60-year-old? That's maybe a different story, but still I would consider it based on considerate planning and also the interaction in our multidisciplinary heart team. And there are some facts and some aspects that might fuel or might drive the patient more to surgery, and there are others that drive the patient more to TAVI. So if the patient is below 60 years old, and especially when you're considering a mechanical prosthesis, then I think the patient should go for surgery. If there is concomitant aortopathy, which is often the case in bicuspid valves, especially if the aortas are dilated or there is a coarctation, then of course surgery is the way to go. If there is excessive root calcification based on CT scanning, that's also a patient that I would send for surgery. Even if the patient is 80 years old and he is low risk, then I think if there is excessive calcium and we anticipate based on the CT scanning that there is a relatively high risk for mild or more PVL, we would send the patient for surgery. Low coronary ostia, because why would you risk coronary obstruction? A highly complex coronary artery disease, if CABG is better than PCI, then also we would send the patients for surgery. And when there is concomitant valvulopathy that needs to be addressed by surgery, then of course combined aortic and other valve surgery would be recommended. On the other hand, if we move to an older age population, then again we would more consider TAVI. The same way, if there is presence of any comorbidity, we would also consider TAVI. And if the transfemoral approach is possible, then also the likelihood of us selecting TAVI as the treatment of first choice is getting higher. So in conclusion, I think TAVI is feasible in severe bicuspid aortic stenosis. The latest generation valves have the required features for success. 3D imaging planning is essential. And do we need to refine our pre-procedural imaging or planning? That is the question, and this is where hopefully BioValid X will come up to fill in the gaps. And I agree that we do need randomized trials at the end of the day, comparing TAVR with SAVR in patients with bicuspid aortic stenosis to come up with a final conclusion. Thank you for your attention.
Thank you very much. You have answered a lot of my questions. Is there any other question to be asked?
Okay, now, I would like to ask you about the incidence of paravalvular leakage in these patients, special patients.
Yeah.
Is the same as in TAVI, in tricuspid valve.
Yeah, so I think with the next generation or the latest generation devices that introduce the sealing fabric, I think the difference in significant paravalvular leaks between bicuspid and tricuspid after TAVI is no longer significant. And this follows the data from the TVT registry, and over almost 3,000 patients with bicuspid aortic stenosis, there was no difference in the presence of mild, moderate, or more PVL between the bicuspid and the tricuspid valves. And this is, the situation is completely different with 5 or 6 years ago with the SAPIEN XT and the core valve. And I think this is where probably also, if you compare Evolut R with Evolut Pro, where the difference will be. I think in tricuspid aortic stenosis, at least in my practice, there is no difference in outcome between Evolut R and Evolut Pro. With the bicuspids, probably Evolut Pro will be more performant than the Evolut R. So again, I think paravalvular leak in properly selected patients should not be an issue for patients with bicuspid aortic stenosis.
Okay. And another, balloon sizing technique is a very helpful tool in TAVI and BAV. Is always necessary or not?
I think balloon sizing is misleading, honestly. So in the majority of my cases, I will rely on CT scanning. Sometimes when I have high-risk patients with a lot of calcium that the surgeon really turned down the patient, then I would like to downsize somewhat because of the excessive amount of calcium, and then sometimes balloon sizing comes into play.
Okay, thank you.
Yeah.
Can we have the microphone, please?
Thank you very much for the great talk. I mean, both your talks with Dr. Chalapas really went well together. You both alluded to the fact of LVOT and calcium and sizing and sealing, and I think we can really use that LVOT to our benefit, because especially if it tapers down, we can go with a smaller valve and maybe upsize with the balloon and get a good sealing effect without disrupting the annulus. And we've used that a lot of times with great success, just really looking at LVOT a few millimeters below.
Yeah, so I think the LVOT, we need to take into consideration the dimensions of the LVOT, not only for paravalvular leaks, but also for conduction disorders, as I mentioned. The downside, however, is if you will end up with selecting a smaller prosthesis, you will have more prosthesis-patient mismatch. And this is where, at this point in time in the randomized trials, at least with self-expanding valves and with also balloon expandable valves, at least in the intermediate and high-risk trials, there was the differentiator with surgery, that the valve performance was superior with the transcatheter valve. And I'm not sure whether we want to give that up. I think the more challenging the anatomy gets and the more calcium there is, I would be more and more inclined to try out the completely repositionable retrievable device, so the mechanical expanded lotus device. Because then you can completely implant the valve and then assess whether you're happy or not. If you're not happy, you can then reposition, and then you can fine-tune your final valve positioning. Yeah.
Thank you, Dr. Mieghem. Thank you.
Thank you.